in full disclosure, originally when I was invited, I wasn't sure that this debate was still timely. I thought this was accomplished 10, 15 years ago. My colleagues in the functional neurologic disorders world, of which psychogenic seizures are a part of, really, and I thought that we knew that it was not ethical, but I understood by speaking with other colleagues that neurologists, epileptologists are still using this technique quite commonly. And so I think it's very important that I speak with colleagues to try to share why I think it's unethical to provoke non-epileptic seizures. My argument about why it's unethical, first I want to start out and to say that the Congress has asked to use the term psychogenic seizures. My preferred term is functional seizures to associate the disorder with FND, functional neurologic disorder, and also to destigmatize the name for patients, as it's quite confusing and stigmatizing. But this is a common, real, and debilitating disorder. Patients are not faking symptoms, and they feel very stigmatized by the time they come to see us in neurology. They've been through the medical system before. Their loved ones are suffering. And so I believe our job as neurologist or physician or clinician or whatever it is that we do is to help patients understand what they have, what's going on. That's the diagnostic part. But also to get them on the best possible path to get better and for recovery. And this involves not abandoning the patient, not turning them off by the language that we use, and not losing their trust. And so that's really part of my argument. And we already know that a lot of the patients that we see in neurology never make it to their follow-up in the mental health system because they feel we got it wrong, or they didn't like how things were explained to them, or they didn't believe us, or they didn't feel it felt right. So since the debate is about ethics, I'm not an ethicist. I needed to begin with learning some of the ethical principles behind it. There's 4 basic ones. There may be more, but one is autonomy. And patients, that means patients have the right to make a choice, and they need to be informed clearly, transparently of what that choice is. The provocation is also called suggestive seizure manipulation, where you suggest that a seizure is going to happen. And that's somewhat deceptive because an epileptic seizure is not, likely happening. It's going to be kind of proving that this might be psychogenic in origin. And unless that's clearly explained to the patient, which most groups, at least in the study that was published recently by Gross and others, showed that 70% of epileptologists still use this, and they don't get clear, informed consent written about what this is. The other principle of ethics is justice. That is, we should treat every patient equitably and fairly. And most of the studies published in this area that shows that it works and speeds up the diagnosis, most of the studies show that it's only done in patients where you suspect that this is not epilepsy. So that's not really equitable, and you will miss patients that you think have epilepsy but don't, and it's something that's really, I think, important. The third ethical principle is non-maleficence. That means we should not do intentional harm to patients. And I would consider being at all deceptive in any way about what we're actually doing with our technique is problematic for this ethical principle, because even if one patient loses trust in us by this technique, then we are not serving our purpose as ethical-based clinicians. This group of patients already is distrustful, many of them, of the medical system in how they finally get to us. And so they watch our language very closely. And I think that not every neurologist is comfortable in this group of patients, and we should be. It's part of our wheelhouse. The last ethical principle is beneficence, that is, to do good for the patient. And the way I interpreted this is provoking seizures patient-centered? Is this the best thing for the patient? Does this improve outcomes and things like that? And to me, it's somewhat more doctor-centered and paternalistic. It's doctors feeling it's good for patients because we'll make the diagnosis sooner, which, I think Dr. LaFrance will probably say that, making a sooner diagnosis will help outcomes, but I am going to refute that because we really haven't studied outcomes nearly enough. We've ignored this disorder for a long, long time. I think we need to study outcomes better. A recent study by Fredwall and all just this past year, it was done in pediatrics, showed that it wasn't time to diagnosis that was important because they didn't capture seizures in more than 50% of the patients. It was time to treatment that led to more remission and better results. So I think there's a lot of things that we still need to learn. My argument about why we should not provoke psychogenic non-epileptic seizures is going to include, first, that it's not ethical, as I think I showed you. And second, that it's not necessary for diagnosis. There's always going to be patients where you cannot confirm whether they have a typical episode on video EEG. And that number isn't small. Monitoring, as I already mentioned, as I will mention, is not available for everyone. And we have other ways to obtain that. I will also argue that it is not patient-centered, it is more physician-centered to push for provocation, to get patients moving on into other practices, because I believe that this is a challenging disorder. Not everybody feels comfortable with what to do with these patients, and we need to train our clinicians to do better and to really feel much more comfortable like they would with any patient, because physicians, they want to be ethical, they want to do the right thing. And I think more and more people are believing that this disorder is real and, patients do want to get better. If we do want to try to elicit seizures, then I think the ILAE, the International League Against Epilepsy, is working towards a way with some kind of consensus or guideline on how to do that. And it should be probably before bringing patients in for monitoring in the outpatient EEG lab, disclosing clearly what we're doing it for everyone before we know what the diagnosis is, and using standard techniques like hyperventilation and photic stimulation, which are techniques that can bring on epileptic seizures, and we should just not mislead patients. Anyway, that's going to be my main argument. And I think I'm going to counter Dr. LaFrance, who's going to be pushing for earlier diagnosis is better for outcomes, and that's where I'm going to point to the study about it's earlier to treatment, I believe, and that by the time they get to us, it's already about 7 years. It's late. What's another 6 months or a year, as long as we wait for the patient to be ready for treatment and not abandon them in our practices.